Hello everyone, I'm Dr. Niharika Jha and today I will be discussing about tofacitinib and its uses in dermatology. So what is tofacitinib? Tofacitinib, it is a genius kinase inhibitor and it is available in both oral as well as topical forms. Already it has been used in various systemic inflammatory disorders and its efficacy has been well established in certain diseases such as rheumatoid arthritis, ulcerative colitis, and psoriatic arthritis. But now in dermatology also, we are finding a lot of uses of tofacitinib. It is now being actively explored for cutaneous disorders such as those disorders in which the problem is because of the patient disimmune responses. It is particularly used in those patients who are not responding to the classical immunosuppressives, or because of one reason or the other, we are not able to start the patient on the classical immunosuppressives or other therapies such as the biologicals. So what is tofacitinib? Is it an immunomodulator? Is it a biological? What is it? It is an immunomodulator and it belongs to the family of Janus kinase inhibitor. So I'm using this Janus kinase again and again. What is exactly Janus kinase inhibitor and how does it inhibit? What is the mechanism of action? Let us learn about it. So for that, we need to learn about two things. One is the Janus kinase, which is the JAK, and then there is STAT. What is STAT? It is a signal transducer and activators of transcription. So these are the two full forms that we need to know. JAK stands for the Janus kinase inhibitor, and STAT stands for signal transducers and activators of transcription. So tofacitinib, in short, inhibits this JAK-STAT pathway. So with the help of this very simple diagram, I'm going to explain you the mechanism of action of tofacitinib. So normally what happens in any autoimmune disorder, an inflammatory cytokine or might be a growth factor, it comes and binds to this cytokine receptor or the growth factor receptor, the extracellular part of the cytokine receptor or the growth factor receptor to which comes and binds the inflammatory cytokine or the growth factor receptor. In the intracellular part of this receptor is present the JAK, which is the Janus kinase. Once this inflammatory cytokine comes and binds to the receptor, the JAK gets activated. And what does it do? It causes the phosphorylation of STAT. So what is STAT? As I've already told you, STAT is signal transducers and activators of transcription. So once the JAK gets activated, it causes the phosphorylation of STAT. And once STAT becomes phosphorylated, it becomes activated. On activation of STAT, what happens? Gene transcription happens, and a lot of cytokines are produced, which are required for the pathogenesis of diseases such as vitiligo, psoriasis, alopecia areata, atopic dermatitis, etc. So, what is tofacitinib doing? Tofacitinib is blocking the Janus kinase. It is a JAK inhibitor. Okay. So, what it is doing? It is blocking the Janus kinase. It is a Janus kinase inhibitor. So when JAK gets inhibited, it is not able to phosphorylate STAT. Once the STAT does not get phosphorylated, it does not get activated, and as a result, gene transcription of a lot of cytokines is stopped. It comes to a halt, and those cytokines which are required for the pathogenesis of the diseases, as I mentioned, they are not produced in the body, and hence tofacitinib can be used in the treatment of disorders such as psoriasis and vitiligo and alopecia areata and atopic dermatitis. Currently, we are using tofacitinib for all these diseases in dermatology. In short, I will explain it to you again. Normally, what happens? Inflammatory cytokine comes and binds to the receptor. JAK gets activated. JAK activates STAT by phosphorylating it, and as a result, gene transcription of cytokines happen, and cytokines are released into the body for the pathogenesis of the diseases. But what is tofacitinib doing? It is inhibiting the JAK. JAK gets inhibited, STAT does not get phosphorylated, gene transcription does not happen, and cytokines are not released in the body. So this is how it inhibits the JAK-STAT pathway. It is also known as the JAK-STAT inhibitor or the JAK inhibitor. If we talk about Janus kinase, there are 4 types of JAK, 4 isomers. These are JAK 1, 2, 3, and 4. Talking about tofacitinib in particular, tofacitinib inhibits JAK 1 and 3 more than JAK2, it does not inhibit JAK4. Yeah, because of all these reasons, Jack is coming up as an attractive and an preferable option. So, what are the causes? The reasons being, first of all, it is easy to give it to the patient. It is available in oral forms or topical forms, unlike the biologicals, which we need to give intravenously or might be subcutaneously. So, the injectable route can be avoided. Secondly, no reports have come up which shows that there's a potential of generating neutralizing antibodies, and it causes inhibition of signaling from multiple cytokines, and hence it can be put to use in many disorders. So that is why JAK inhibitors are coming up as an attractive option. Now, there are certain diseases for which tofacitinib has been already approved by the FDA, and these include rheumatoid arthritis. It was approved for the use in rheumatoid arthritis in 2012. In 2017, it was approved for psoriatic arthritis, and in 2018, it was approved for the use in ulcerative colitis. Let us learn about the names of a couple of more JAK inhibitors. So ruxolitinib, it is being used in the treatment of polycythemia vera and myelofibrosis, and baricitinib, it is being used in treatment of rheumatoid arthritis. Coming to certain key pharmacological concepts related to oral tofacitinib. The peak levels, they reach in about 30 minutes. 74% of bioavailability is seen. Plasma protein binding is about 40%. Half-life is around 3 hours. Metabolism, about 70% of the metabolism is there in the liver, is seen in the liver. So 70% hepatic metabolism is seen, and it is primarily mediated by CYP3A4, minor contribution from CYP2C90. Now we need to remember these two names. Why? Because when we will study drug interactions with tofacitinib, you will come to know why it is important to know how the metabolism is mediated. Excretion is about 30%, renal excretion. So, coming to the clinical uses of oral tofacitinib in skin disorders. So, not only oral, tofacitinib, and now we know that topical tofacitinib is also available in the market, but obviously the search started from the oral, oral route itself, the oral tofacitinib. So, as I told you that as of now, we are using tofacitinib primarily in the treatment of psoriasis, atopic dermatitis, alopecia, areata, and vitiligo. In fact, psoriasis was the first disease for which tofacitinib was evaluated as a treatment option. How does it work in psoriasis? So, it inhibits the JAK-dependent cytokines such as interleukin 12, 23, and interleukin 17 as well. So, if you remember, ustekinumab is a biological which inhibits interleukin 12 and 23, and secukinumab is another biological which inhibits interleukin 17. So, tofacitinib is not a biological. Compared to obviously biologicals, it is cheaper, and it can be used in the treatment of psoriasis because it is inhibiting the same interleukins, interleukin 12 and 23, as inhibited by ustekinumab, and interleukin 17, which is inhibited by secukinumab. We already know that it has been FDA approved in psoriatic arthritis. In fact, its efficacy has been compared to that of adalimumab. Coming to the next disease, which is alopecia areata. So, the usefulness of tofacitinib in alopecia areata as a treatment option, it was actually a serendipitous discovery, which led to the further exploration of tofacitinib as a potential treatment option. So what did tofacitinib do? It causes the inhibition of JAK-dependent cytokines, which are the interferon gamma and interleukin 15, which drive the activation of autoreactive CD8 T cells. And this step is particularly very crucial in the pathogenesis of alopecia areata. So if we talk about the overall outcome, patchy alopecia areata, it responds much better than alopecia totalis and alopecia universalis. A higher dose gives a better response than a lower dose. It can be combined with oral steroids and other treatment options such as narrowband UVB, etc. Now, I have purposefully hidden the dosage of tofacitinib. The reason being, I don't want to be a source of quackery. I don't want people who are not dermatologists or who are not even doctors to treat alopecia areata using tofacitinib. So on purpose, I have hidden the dosage for the same. Now, before starting the patient of alopecia areata on tofacitinib, it should be made very clear to the patient as requires a proper pre-treatment counseling that it is a waxing and a waning kind of disorder and relapses can be seen. There is no guarantee that after cessation of the therapy, patient will never develop alopecia areata again in his or her life. So you have to make the patient aware of the unpredictability of the relapse following the cessation of the therapy. In fact, as it has been seen in many cases, patients have given beautiful responses to tofacitinib, but after the cessation of the therapy, the relapse of the disease is also fast. In some cases, it has been seen. So it should be made clear to the patient very well before starting the patient on alopecia, of a patient of alopecia areata on tofacitinib. The next disease is vitiligo. So how does tofacitinib helps in vitiligo? It inhibits interferon gamma signaling, which drives the CD8 T cell mediated melanocyte destruction. Satisfactory repigmentation can be seen with both the topical as well as the oral tofacitinib. Better outcome is seen in those areas which are sun exposed, and we can combine tofacitinib along with other treatment modalities such as narrowband UVB. In atopic dermatitis, what does tofacitinib do? Tofacitinib, it causes a decrease in interleukin 4, 5, and 13, which are involved in the pathogenesis of atopic dermatitis. So I'm not sure if you know, mepolizumab is a biological which is, being evaluated for treatment of atopic dermatitis. What it does, it inhibits interleukin 5. Apart from treating atopic dermatitis, it also reduces atopic dermatitis associated itch or pruritus. And how does it do that? By what it does is that JAK signaling in nerves is critically important for regulation of atopic dermatitis associated itch because it's a JAK inhibitor, so that also gets inhibited. Availability. Now, oral tofacitinib, it is available as oral as well as topical forms. In oral forms, it is available as tablets of 5 milligram, 10 milligram, and 11 milligram. The tablet of 11 milligram is known as the extended release tablet. Many companies are making it, so the companies promoting tofacitinib, if we talk about the company name, it can be found as Tofatas, Novanib CT, or Tofasure. These are some of the brand names. The topical tofacitinib, it is available as 2% ointment or gel, and Tofatas, it is available as Tofatas or JAK Autostat. So Tofatas is present in ointment form, and JAK Autostat, it is present in the gel form. It is available in the gel form. Again, tofacitinib in the topical form can be used in the treatment of these diseases as I've discussed: psoriasis, alopecia areata, vitiligo, and atopic dermatitis. How to apply tofacitinib? It has to be applied in a very thin layer twice a day to apply around 20%, in about 20% of the body surface area. Obviously, certain side effects or adverse effects can be seen with the treatment of topical tofacitinib, which are not major. Minor side effects such as erythema, hyperpigmentation, transient acne, minor changes in the lab abnormalities can be seen. So before starting any patient on oral tofacitinib, we have to conduct certain tests. Certain battery of tests have to be done, and one we have to do before starting the patient on treatment with tofacitinib, and then we have to repeat also. That is, we have to monitor the patient again after starting the patient on tofacitinib. So before starting the patient on tofacitinib, we have to go and we have to ask the patient to get tested for the routine blood investigations, which include CBC, KFT, which is the renal function test or the kidney function test, LFT or the liver function test, CPK levels, fasting lipid profile has to be done. Then we have to get the triple H test done, which is the serology for HIV, Hep B, and Hep C. We have to rule out tuberculosis. So screening for tuberculosis can be done by using MONTU, or we can go for quantiferon TB gold test, as well as we can also get a chest X-ray PA view done to rule out any tuberculosis, active tuberculosis in the patient. This is before starting the patient on tofacitinib. Once the patient has been on tofacitinib, we have to repeat the investigation. That means we have to monitor the patient. So for monitoring, we have to do follow up at 1 month post treatment initiation, and then every 3 months. So at 1 month, it has to be done for CBC, KFT, LFT, and fasting lipid profile. This can be done after 1 month, and then again after 3 months, we have to repeat this check. For TB screening, we have to repeat it annually. That is, once in a year, we have to rule out tuberculosis if the patient is that long on tofacitinib. Now we have to make sure, if the patient has any infection at the time of starting tofacitinib, particularly any opportunistic type of infection, tuberculosis, herpes, or might be, any cellulitis, it's better not to start the patient on tofacitinib. Hold on to tofacitinib, do not start it. If the patient is having moderate to severe renal insufficiency or hepatic impairment, start on a lower dose, about 5 milligrams. Then active infection, obviously we do not have to start the patient on tofacitinib. Immunization, we do not have to recommend any kind of live immunization or live vaccinations if the patient is on tofacitinib. It is better to give such kind of vaccine 2 to 4 weeks prior to the initiation of this particular drug. What about the blood counts? If the ANC is less than 1000 cells per cubic mm, or the absolute lymphocyte count is less than 500 cells per cubic mm, or the hemoglobin is less than 9 grams per deciliter, do not start the patient on tofacitinib. What are the contraindications and the precautions? So we do not start on tofacitinib infection, as I told you, if the patient is having active tuberculosis or localized infections such as cellulitis, sepsis, or opportunistic infection. Seropositivity, if the patient tests positive for Hep B, Hep C, or HIV, obviously do not start the patient on tofacitinib. Hematological abnormalities, ALC less than 500 cells per cubic mm, ANC less than 1000 cells per cubic mm, and hemoglobin less than 9 grams per deciliter. Severe hepatic impairment, do not start the patient on tofacitinib. Now, obviously, if the patient is sensitive or is having reactions to tofacitinib, drug reaction to tofacitinib, do not start the patient on tofacitinib. And when do we interrupt the treatment? We interrupt the treatment. By interruption, I mean if the patient is already on tofacitinib, but we have to stop the treatment in between. If the patient develops a serious infection, any kind of opportunistic infection, sepsis, or hypersensitivity reaction, cell counts have already developed. If the patient develops cell counts go below the advised level, stop the treatment with tofacitinib. Hemoglobin level, I've already told you, but also keep in mind, if after starting the tofacitinib, the hemoglobin level drops by more than 2 grams per deciliter, stop the treatment with tofacitinib. If we are suspecting drug-induced liver injury. What are the adverse effects with oral tofacitinib? So topical we have already discussed. What about the oral tofacitinib? Obviously, it can result in activation or reactivation of infections, be it tuberculosis, cutaneous infections such as herpes zoster, or they can be UTIs or other opportunistic infections. Malignancies such as solid organ cancers, melanoma, non-melanoma skin cancer, and lymphomas. GIT problems such as perforations and obstruction. Laboratory abnormalities such as hematological, derangements or liver derangements or dyslipidemia. Obviously, that is why we get a lipid profile done before starting the patient on tofacitinib. And a hypersensitivity reaction such as urticaria, angioedema, backache, or musculoskeletal, other musculoskeletal problems such as arthralgia, hypertension, headache can also happen. What about the special populations of special situations? Coming to pregnancy, talking about pregnancy first. In pregnancy, it is a category C drug. And category C drug, we know that it should be started only if the benefits outweigh the potential risks. Lactation, ideally, those patient mothers who are lactating should not be started on tofacitinib. If the patient is already on tofacitinib, then breast feeding is best avoided during the treatment, or at least a gap of 18 hours has to be maintained from the last dose, or 36 hours if the patient is on XR, extended release, that is the 11 milligram tablet. Pediatric population, again, it is better to avoid the oral tablets. And if you are starting it in a pediatric population, then benefit to risk ratio has to be discussed properly in detail with the parents or the guardian before initiation of the treatment. Same is with the geriatric population. Now, coming to the drug interactions. Now, drug interactions, as I told you, that we need to learn about the mediators of the metabolism. So, if a patient is on ketoconazole, which is a strong CYP3A4 inhibitor, so what does it do? It causes increased exposure to tofacitinib. So, we have to start the patient on a lower dose. Or might be if the patient is fluconazole, fluconazole, which is a CYP2C19 inhibitor. Again, the clinical impact is that there is an increased exposure to tofacitinib because its metabolism is getting hindered. When the metabolism is getting hindered, so more amount of tofacitinib is available to the patient. As a result, we have to do dose adjustment. That means we have to start at a lower dose. What about rifampicin? It is a CYP3A4 inducer. What do you mean by that? It is an inducer, that means it will cause increased metabolism of tofacitinib and hence reduced clinical response will be seen in those patients. Ideally, rifampicin and tofacitinib should not be co-administered. It is not recommended. And immunosuppressive drugs such as azathioprine, cyclosporin, or methotrexate, they should not be given along with tofacitinib. It is ideally not recommended. So this is all about tofacitinib that we need to know at dermatologists. We should know the mechanism of action, so we will be able to judge which patient is a better candidate for tofacitinib. We should know where it is being currently used, psoriasis, alopecia areata, vitiligo, and atopic dermatitis. Then we should know what are the investigations that we need to do: CBC, LFT, KFT, lipid profile, CPK levels. We have to rule out any tuberculosis, and serology for triple H has to be done. Follow-up has to be done initially at 1 month post treatment and then 3 monthly. Screening for tuberculosis has to be done annually. Then we should not start the patient on tofacitinib if there is any active infection, any hypersensitivity reactions, any hematological abnormalities, severe hepatic derangement, or if the patient is positive, has tested positive for Hep B or Hep C or HIV. And we know when to stop with the treatment. So these are the important or the key points about tofacitinib. I hope the lecture was useful to you.